Good evening. Welcome to yet another lecture series for the exams by AATRAL group, a part of IMA MSN. I think all of you are welcome into the Medical Student Network of Indian Medical Association. Today we'll be having a cardiovascular case being discussed by Dr. my good friend Anirudha, who did his MD General Medicine from Stanley Medical College. And I think it would help you revise for your exam and get through your exams.
Hello, good evening, everybody. I'm Dr. Anirudha. I'm a physician in Stuverrt Hospital. So, this will be a short, concise revision of whatever you have learned. Okay, this is just entirely to practice you for your upcoming exams. Okay, so can we start, Dr. Joy?
Hi. I think you didn't hear my voice, so I'll re-say it again. So today we are welcome to IMA MSN JDN, and today we have a lecture series on cardiovascular case for a final year exam by the AATRAL group, and it would be useful for your exam. My good friend Anirudha, who is a physician, graduated from, he did his MD General Medicine from Stanley Medical College, would be the right person to teach you all tips to get through your exam. So let us go ahead and start right away. Thank you.
So, Dr. Aishwarya, can we go on to the presentation?
Yes, sir. Thank you. Good evening, everyone. This is Aishwarya here to present a case on cardiovascular system. A 45-year-old Mr. Shankar residing in Tambaram, who is a teacher by profession, came with chief complaints of breathlessness for the past 6 months, easy fatigability for the past 1 month, and palpitation for the past 1 month. History of presenting illness. The patient was apparently normal 6 months back, after which he developed breathlessness, which was gradual in onset, progressive in nature, initially of NIHA grade 1, that is only with exertion, now has progressed to NIHA grade 4. Initially, it was aggravated by exercise and relieved by rest. Now it occurs at rest itself. History of orthopnea and paroxysmal nocturnal dyspnea present. For the past 2 months, PND occurred first, followed by orthopnea. History of palpitation for the past 1 month, which was sudden in onset, irregular in nature, precipitated by exertion and relieved by rest, not associated with syncope and chest pain. History of easy fatigability for the past 1 month, which was gradual in onset, progressive in nature, aggravated by exertion and relieved by rest. History of bilateral leg swelling present for the past 1 month. History of cough with blood-stained sputum for the past 1 week. No history of abdominal distension, right hypochondrial pain, puffiness of face, chest pain, fever associated with sore throat and joint pain, voice change and dysphagia, oliguria, recurrent upper respiratory tract infection, limb weakness, and yellowish of discoloration of skin seen. Past history, history of fever associated with sore throat, rheumatic fever, which occurred 30 years back, history of penicillin injections, which was given every month since diagnosis of rheumatic fever. The patient was not compliant for the treatment. No history of similar illness in the past. No history of hypertension, diabetes mellitus, tuberculosis, asthma, or epilepsy. No history of chronic respiratory tract infection. No history of surgeries. No history of similar illness in parents, siblings, or children. No history of cardiac illnesses in the family. Personal history. The patient is on mixed diet. He is a non-smoker or non-alcoholic. He has normal bowel and bladder movement and has disturbed sleep. Summary: a 45-year-old male with chief complaints of dyspnea for the past 6 months, palpitation and easy fatigability for the past 1 month, orthopnea and paroxysmal dyspnea, bilateral pedal edema and hemoptysis with a past history of rheumatic fever. Thus, I would like to examine the cardiovascular system. Differential diagnosis: left atrial myxoma, cor triatriatum, ball valve thrombus of left atrium, Caricom's murmur of mitral valvulitis, Austin Flint murmur of aortic regurgitation. General examination: the patient was conscious, oriented to time, place, and person, moderately built and nourished, no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy. Bilateral pitting pedal edema was present up to the knee level. External markers of rheumatic fever and like joint swelling, erythema marginatum, subcutaneous nodules were not present. External markers of infective endocarditis like anemia, jaundice, clubbing, splinter hemorrhages, Osler's nose, Janvey lesions or arthritis was not present. External markers of coronary heart diseases like arcus senilis, xanthelasma, xanthomas, nicotine stains and obesity was not present. External markers of congenital heart disease like hypertelorism, low set tears, polydactyly, syndactyly, webnet or kyphosis was not present. Vitals: pulse 90 beats per minute, irregular rhythm, variable in volume and character with normal condition of the vessel wall. All peripheral pulses were felt. No radio-radial or radio-femoral delay was seen. Heart rate 1 or 2 beats per minute. Pulse deficit of 12 beats per minute was seen. Blood pressure. So, blood pressure of 120/80 millimeter of mercury was measured in supine position in left arm. Respiratory rate 15 breaths per minute. Temperature afebrile. Jugular venous pulse was elevated 5 centimeter above the sternal angle. Cardiovascular system examination. Inspection. Chest wall appears to be symmetrical and ellipsoid in shape. Trachea appears to be in midline. Apical impulse appears to be in left fifth intercostal space. Epigastric pulsations were visualized. No venous engorgement or precordial budge seen. No scars, sinuses, and fistula was seen. Palpation. Tracheal position is confirmed to be in midline. Apical impulse is felt in left fifth intercostal space, 1 inch medial to the mid-clavicular line, which was tapping in nature. Epigastric pulsations felt on the tip of palpating finger. Grade 2 parasternal heave present. Palpable P2 present. Presence of diastolic thrill over precordial was seen. Auscultation. Mitral area. S1, S2 heard. Loud S1. Low-pitched, rough, rumbling, mid-diastolic murmur of grade 4, heard with a bell of stethoscope with opening snap and pre-systolic accentuation with a patient in left lateral position and breath held in expiration. Tricuspid area, S1 and S2 heard. Pulmonary area, S1 and S2 heard. P2 was loud. Aortic area, S1 and S2 heard. Other system examination, abdomen, tender hepatomegaly present, no other organomegaly. Respiratory system, bilateral air entry present, bilateral basal crepitations were heard. Central nervous system, no focal neurological deficits present. Probable diagnosis, a case of acquired valvular heart disease, probably due to rheumatic etiology affecting the mitral valve, most likely mitral stenosis with atrial fibrillation and has signs of right heart failure and pulmonary hypertension. Investigations, basic, complete blood count, hemoglobin, erythrocyte sedimentation rate, random blood glucose and lipid profile. Specific investigations like electrocardiogram, echocardiogram, X-ray chest, PA view, Doppler and cardiac catheterization. Treatment, medical, penicillin prophylaxis, salt restriction, beta blockers, warfarin, digoxin, diuretics and infective endocarditis prophylaxis should be given. Surgical, mitral valvotomy or percutaneous mitral balloon valvotomy or mitral valve replacement. Thank you.
Hello,
Yes,
am I
sir.
audible?
Yes, sir.
Yes, Dr. Aishwarya. Okay, very good. First, slow and steady present morning. That is very good. Okay, sorry.
Yes, sir.
Let us go over the case one by one. History start pannanga. Go to the first slide. Okay. So our patient presented, who is a teacher. He is 45-year-old. He presented with breathlessness. It started 6 months before.
Yes,
Okay.
sir.
Then fatigability and palpitations. Okay. History of present illness. So before 6 months, so the breathlessness started 6 months back. It was initially NIHA grade 1, and it went up to grade 4. Sure. NIHA grade கொஞ்சம் explain பண்றீங்களா?
Sir, breathlessness on exertion is known as NIHA grade 1, sir.
Okay.
And that is with more than ordinary activity. And
Okay.
then grade 2 will be with normal activity, ordinary activity
Okay.
for that particular patient. Then grade 3 will be less than normal activity. Grade 4 is at rest, sir.
Yes. Okay. So this was initially a NIHA grade 1 and has slowly progressed to grade 4. Sure. And initially aggravated by exercise and relieved by rest. Now he is present even at rest. Sure. Orthopnea and PND for the past 2 months. Okay. PND occurred first, followed by orthopnea. Sure. What is PND?
Sir, PND is the patient lies down and then after 2 to 5 hours after lying down, he will feel breathlessness and then he sits upright and then he feel relieved of the breathlessness.
Okay. So what is the pathophysiological mechanism for PND?
So one is the increased venous return to the atrium and the other is the upward push of the diaphragm when the patient lies down. So
Okay. So PND usually occurs a few hours after the patient goes to sleep. It is a slow process. It indicates there is some right or left heart failure. Usually it is a left heart failure where the left heart is not able to, is not compliant with the increased blood flow coming to it. When the patient lies down, the venous return increases, so more of the blood goes to the right side of the heart from where it goes to the lungs. And then from the lungs, it goes to the left atrium and left ventricle. And the left atrium or ventricle is not able to dissipate this load, then there is a backflow that leads to PND. Am I not audible?
audible, sir.
Okay. So when this process goes on and on, and the failure, when the compliance of the atrium falls further, then it becomes an orthopnea where patient will lie down and within minutes he will get the dyspnea. So that is why PND will occur first, followed by orthopnea. Usually it is seen in left-sided heart failure, more so in left ventricular failure and also in left atrial. Okay, go to the next slide. Palpitations for the past 1 month, which was sudden and onset, irregular in nature, precipitated by exertion. So when you mean it is irregular in nature, it means that how do you describe that? Whether it was present throughout, but the palpitations were irregular, or it comes and goes. How do you describe that?
Sir, it was present throughout, sir, but the nature of the palpitation was irregular.
Irregular, sure. Okay. So what will you think of when the patient says it is present throughout and it is irregular in the nature?
Most probably atrial fibrillations.
Okay. So what will you think of when the patient says it is coming and going?
Tachycardias.
So this can be a ventricular arrhythmias, or it can also be atrial fibrillation, where it can call it as paroxysmal atrial fibrillation. Sharya?
Yes, sir.
Okay. History of EC fatigability for the past 1 month, it is gradually progressive. And bilateral leg swelling. Okay. Next slide. Okay. So the negative history report இருக்கீங்களா?
Yes, sir.
You say, so what will you think of the patient has abdominal distension along with your set symptoms?
Sir, right heart failure, most probably you'll think of abdominal distension and ascites, right hypochondrial pain.
Hypochondrial pain, puffiness of face irunda.
In advanced congestive cardiac failures, we can see puffiness of face.
Limb weakness nu mention பண்ணிருக்கீங்க. Is there any
Sir,
significant?
thromboembolism
Okay.
because we see atrial fibrillation kind of history also. So
Okay. Voice change and dysphagia.
Sir, Ortner's syndrome, sir, like left atrial enlargement will compress the recurrent laryngeal nerve, so which can cause.
Is there any other one more reason mitral stenosis apart from enlarged left atrium? Something to do
For
with
voice.
pulmonary artery for voice change and dysphagia. In some patients, pulmonary artery hypertension can also cause this.
Okay, sir.
Very rare. Even pulmonary artery dilatation irundha kuda this can happen.
Okay, sir. Yes, sir.
Yes. Okay, go to the next slide. Past history, fever associated with sore throat. Okay, rheumatic fever, penicillin injections, similar venous fever, no other comorbids, no surgeries. So what do you mean by chronic respiratory tract infection?
Sir, pulmonary edema madri they will have prone to more respiratory tract infections, pulmonary congestion or edema. And
Okay.
so most probably if you are that pulmonary edema will be caused due to mostly mitral stenosis. So
One other thing, the recurrent respiratory tract infection can also be seen in congenital heart disease.
okay, sir. Yes, sir.
Okay. Go to the next slide. Family history, no history of similar illness in the family. So we right now have a broad idea that this is something related to the mitral valve.
Yes, sir.
So do we know any congenital causes for mitral valve disease? We know that most commonly mitral stenosis அப்படின்னு சொன்னா we think of rheumatic heart disease. Any
Yes,
other
sir.
causes?
Car triatrium.
So your more commoner ones is mucopolysaccharidosis, the Hunter syndrome, Hurler syndrome, அதெல்லாம் இருக்கு இல்லையா? So those things, congenital mitral stenosis. Okay. Or
yes,
similar illness in parents, siblings, அதெல்லாம் இருக்கு. They have to think for congenital heart disease.
okay.
Okay.
Yes, sir.
Personal history, non-smoker, and which part to repeat, doctor? Somebody has.
Sir?
Please repeat again. What is it? Once again. Congenital. Okay, so your congenital causes of mitral stenosis is generally more commonly due to mucopolysaccharidosis. Example, your Hunter syndrome or Hurler syndrome, those things. So apart from acquired rheumatic heart disease, congenital cause வந்து இது சொல்லிக்கலாம். சரியா?
Yes, sir.
Hunter syndrome and Hurler syndrome, Dr. Aishwarya, whoever it is, and Dr. Karthikeyan. Non-smoker, non-alcoholic, normal bowel and bladder habits, disturbed sleep. Anything you will notice in which, okay, questions I will come to the last part. Okay. Anything you can, bowel habits, irregular, will you think of something?
Any carcinoid syndromes, so they are also associated with mitral stenosis.
Yeah, more commonly it is associated with tricuspid valve diseases, but rarely can be associated with mitral valve diseases also. Secondly, in a patient with atrial fibrillation, if he says there is bowel abnormalities, then you have to think of thrombosis of mesenteric arteries. Okay.
Oh, okay,
That is
sir.
one
Yes.
complication. That is one complication of atrial fibrillation. It's like how you can get thrombosis in other arteries.
Okay, sir. Yes, sir.
Yes. Go to the next slide. So summary, easy criticability, and all those things. Okay. So in the summarization, you have to put down what are all the differential diagnosis you think of, and then you can go for examination of the specific system. Okay. So differential diagnosis in this case will be rheumatic heart disease. Okay.
Yes, sir.
And then you can put down other causes. You should not put any examination findings in this. Carry-Coombs fever, Austin Flint number, other examination findings. You should not
Okay,
put
sir.
this in differential diagnosis of history. Sharia?
Yes, sir. Sure, sir.
Yes. Go to the next slide. General examination. Patient was conscious, oriented to time, place, person, moderately built and nourished. Okay. If the patient has icterus, what will you think of? Or cyanosis?
Sir, icterus in some hepatic
So
pathology.
congestive hepatomegaly is one. Okay.
For cyanosis, any congenital heart diseases can
Congenital heart disease. Yes. Congenital heart disease or severe shock cyanosis. What are the types of cyanosis?
central cyanosis and peripheral cyanosis.
Central cyanosis. What is the mechanism?
Any shunt, if their congenital heart disease, left to right shunt, and then a defective oxygenation of the blood will lead to central cyanosis.
Yes, defective oxygenation leads to central cyanosis. Where will you see it in central cyanosis?
Congenital heart diseases are majorly, and then
where will you look for central cyanosis?
Lips, tip of the nose, and then earlobes.
Peripheral cyanosis?
Fingertips, and then
for all peripheries or extremities, you look for peripheral cyanosis, like your fingertips, toes, your tip of nose will also be in peripheral cyanosis. For central cyanosis, you have to look at the lips and tongue. Okay.
Okay, sir.
Yes. There are enough differentiating features between central and peripheral cyanosis. Now, the mechanism of peripheral cyanosis in
vasoconstriction will lead to reduce the blood flow to the particular part.
Reduce the tissue perfusion. So, where are the differentiating features between the two?
Peripheral cyanosis becomes better does not get relieved on oxygenation, whereas central cyanosis gets relieved on oxygenation.
Central cyanosis gets slightly better on oxygenation. Peripheral cyanosis will not be getting better with oxygenation. Peripheral cyanosis gets better with improving the perfusion or by warming the peripheries.
Yes, sir.
Central cyanosis will not change. Okay?
Yes, sir.
Yes. Clubbing. Are there any heart diseases associated with clubbing? Okay.
Yes.
Lymphadenopathy. Can be there in infective endocarditis.
Okay, sir.
Yeah.
Yes, sir.
Okay. So bilateral pitting pedal edema up to knee. What does that denote?
Advanced cardiac failure, sir.
So there is a cardiac failure. It can be right-sided, left-sided, or both. Sharia?
Yes, sir.
Yes. Go to the next slide. External markers of rheumatic fever, joint swelling, erythema marginatum, subcutaneous. சரி, rheumatic fever, joint swelling எப்படி இருக்கும்? How do you describe the arthritis and rheumatic fever?
Sir, it's a migrating polyarthritis, sir. So only major joints will be involved mostly. So one joint will be involved, pain and swelling will be there, and then after some time some other joint, like for example initially the knee gets pain and swelling, then the other knee or elbow will be involved. No residual changes will be seen in that particular joint.
No residual deformity.
Yes, sir.
Correct. No residual deformity. Sherry. Erythema marginatum. What is erythema marginatum?
It is a pale patch surrounding which there is a rim of redness.
Where will you usually see this body?
The ulnar surface of the palms.
Trunk you usually see this. Trunk, back, abdomen, chest, and subcutaneous nodules. அது எங்க வரும்? Subcutaneous nodules usually seen in the extremities and elbow. Sorry. What are other features of rheumatic fever? No migratory polyarthritis, erythema marginatum, subcutaneous nodules.
Sydenham's chorea.
Yes, Sydenham's chorea.
And then laboratory criteria like elevated ESR, CRP, and then fever, and then
Jones criteria. சொல்றீங்களா? I think there is a modified Jones criteria.
Yes, sir.
Yes. சொல்லுங்க பார்க்கலாம்.
Sir, a major criteria and minor criteria. Sir, major criteria includes polyarthritis, erythema marginatum, subcutaneous nodules, Sydenham's chorea, and then minor criteria includes elevated ESR and CRP, fever more than 38.5 degrees Celsius, and then
laboratory evidence.
Laboratory evidence, throat swab for streptococcus infections or elevated antibodies for streptococcus infections.
In the high risk and low risk population divide பண்ணுவோமா இல்லையா?
Yes, sir.
Okay, so high risk population la enna major features irundale podum?
Polyarthralgia or monoarthritis is also taken as major criteria.
Monoarthritis or polyarthralgia itself is enough in
yes,
high risk population. The Indians come under high risk population. Okay?
Yes, sir.
Okay. Markers of infective endocarditis. சொல்லுங்க டாக்டர். Anemia, jaundice, clubbing, splinter hemorrhages na enna? Where will you find this?
So in the fingertips, most probably we see for splinter hemorrhages.
And what is oscular nodes?
Hello. Sir, am I audible?
Yes, you are audible.
Sir, am I audible?
Yes, you are audible, doctor. சொல்லுங்க. Dr. Aishwarya. I think there seems to be some issue with Dr. Aishwarya's connection. Dr. Aishwarya. Yes, please check. No issues.
Sir?
Yes. கேக்குதா உங்களுக்கு?
Yes, sir.
Yes. சொல்லுங்க டாக்டர். What is splinter hemorrhage?
Sir, am I audible?
Yes, Dr. Aishwarya, you are audible. சொல்லுங்க.
நல்லா கேக்
Sir, osseous nodes are small, painful, swollen nodules in the pulp of the distal fingers, sir.
Yes. It occurs due to
Um, hypersensitivity in the
it is a immune complex deposition.
yes, sir. Yes, sir.
Germinal lesions.
Cutaneous manifestations, sir. They are erythematous, and then they are non-painful nodules, sir. Mostly seen in the palms.
Palms and soles. It occurs due to
Embolism,
septic microemboli. And then splitter hemorrhages are seen in the nails.
Nails.
Yes. Okay. Sorry. Criteria for infective endocarditis. Name enna?
Duke's criteria.
Yes. Sorry. Coronary heart disease. What are the external markers?
Arcus senilis, sir.
Xanthelasma enna?
Sir, fat depositions.
Seen in which
In
body?
the ocular manifestations.
Xanthoma. Xanthoma, where it is seen?
Am I audible, sir?
Yes, you are audible, doctor. சொல்லுங்க. Dr. Aishwarya. Dr. Aishwarya.
Sir,
Yes.
xanthomas are seen in the skin manifestation.
Tendon xanthomas and skin sharing. Okay. Yes. Congenital heart disease. Hypertelorism.
Yes, sir.
What is the syndrome? Hypertelorism and heart disease. ஏதாவது இருக்கா?
Sir, Down syndromes.
Low set years.
Low set years for Down syndrome, sir.
Polydactyly. So our patient is a
polydactyly trisomy 18.
What is trisomy 18?
Patau syndrome.
Okay, நான் கன்ஃபியூஸ் பண்றேன். எட்வர்ட் syndrome இல்ல?
Sorry, sir.
சரி, பரவாயில்ல. No issues.
Yes,
see, our patient is a 40-plus-year-old gentleman whom we are suspecting a congenital heart disease.
Yes,
if
sir.
we suspect that way, commoner one is a Marfan syndrome.
Okay.
Okay. So, adode features we have to put in.
Okay.
Arched height, tall height, and the general examination you have to include the height, arm span.
Okay, sir.
Okay.
Yes, sir.
Sure.
Yes, sir.
Eye எல்லாம் check பண்ணணும். We have to look for lens subluxation, dislocation of lens, apart from Arcus senilis and all those things.
Yes, sir.
Blue, அதெல்லாம் இருக்கு. சரி.
Yes.
Go to the next one. Vitals. 90 beats per minute, irregular, variable in volume and character with normal condition of vessel wall. சரி, பல்ஸ் எந்த ஆர்டரியில பாப்பீங்க?
Radial arteries.
சரி, ஓகே. என்னென்ன அசஸ் பண்ண முடியும் ரேடியல் ஆர்டரி? So what are the things in pulse you look for? Rate, rhythm,
Rate, rhythm,
volume.
character, volume, condition of
Hmm.
the vessel wall, sir.
From
And then we look for all the other peripheral pulses
radial.
like temporal, sir.
Yes. So radial artery இதுல என்னென்ன பாப்பீங்க நீங்க சொன்ன rate, rhythm, volume, character இதுலலாம்?
Sir, rate and rhythm we'll see in the radial artery.
Okay.
Whereas for volume and character, we'll look for the carotid.
Yes. And
Condition
for
of the
brachial
blood,
artery?
brachial artery for blood pressure.
Blood pressure. So RRR, B for blood pressure and brachial artery, C for carotid and character of the pulse. Yeah.
Yes, yes, sir.
Condition of vessel wall?
Radial artery.
Okay. Okay. So assume if our patient has pulse rate of 90, peripheral pulses எல்லாமே equally felt ன்னு போட்டிருக்கீங்க. Peripheral pulses, if it is not felt, then you will think of something. ஏதாவது ஒரு ஆர்ம்ல இல்ல ஒரு லெக்ல உங்களுக்கு peripheral pulse feel ஆகல அப்படின்னா, in our case, this is a person with atrial fibrillation. You are palpating for the pulses. You don't find the dorsalis pedis on both the legs.
Mostly in thromboembolism at that site.
Thromboembolism. Yes. Okay. Radiofemoral delay அப்படி போட்டிருக்கீங்களே. Give me one
Yes.
or two past radial and radiofemoral delay. Any heart disease, not specific to atrial fibrillation.
Aortic dissection, most probably we can.
Aortic dissection la radiofemoral delay. Sherry, okay.
Yes, sir.
Aorta is most common thing causing radiofemoral delay. As somebody has answered correctly. Correct. Sherry. Radial delay. எப்பயாவது இருக்குமா? Same if your coagulation of aorta starting
before the
subclavian artery. Okay. And yes, vasculitis mentioned பண்ணிருக்கீங்க. Very good. Samson, name போட்டுக்கணும்ப்பா. சரி. Heart rate 102 beats per minute, pulse deficit 12. Pulse deficit, what do you mean by pulse deficit of 12?
Sir, difference between the heart rate and the pulse rate is counted simultaneously. And then if it is more than 10, we take it to be atrial fibrillation. If it is less than 10, we think of ventricular premature beats.
Okay. Check. Good. Go to the next one. Blood pressure 120 by 80 measured in supine position in left arm. Check. So in patients with atrial fibrillation, blood pressure measurement or value போதுமா, or you have to do it multiple times? Because we know that every beat will be variable. So
Okay.
is one value enough, or you have to do it more than once? If more than once, how many times should you check?
More than once. 3 to 4 times we check.
3 times check minimum, and you have to take an average of that. உங்க patient க்கு அது பண்ணீங்களா?
இல்ல sir.
Yes, next time பண்ணணும். Examல ஞாபகம் வச்சுக்கோங்க.
Yes sir. Yes sir.
Respiratory rate of 15 minutes. Febrile. JVP is elevated 5 cm above sternal angle. So what is the actual JVP?
So normal is up to 3 centimeter
from the sternal angle. Okay.
Yes, sir.
So when you have to give the absolute value, you have to add 5 to it.
Yes,
Sternal
sir.
angle distance on the approximately we count it as 5 centimeter. And so the actual JVP is 10 centimeter.
10 centimeter.
Normal is 8 to 10. Our patient has a borderline upper limit of normal.
Yes, sir. Yes, sir.
Okay. JVP, what are all the waves in JVP?
Sir, ascending waves, A, C, V waves, and descending waves, X and Y waves can be seen, sir.
Okay. So what is the background, the mechanism for all of these waves?
Sir, they directly reflect the right atrium pressure, sir.
Okay. So A wave is caused by
atrial contraction.
okay.
And then C wave by the tricuspid valve reflex. And then the V wave by venous filling in the right ventricular contraction.
Right atrium, venous filling up, it increases. Sorry. X descent.
X descent for atrial relaxation and the Y descent for atrial emptying. Sir.
What is the difference between those two?
Sir, atrial emptying is an active process, sir, whereas atrial relaxation is a passive process.
Okay. ஒரு வாட்டி போய் ரீட் பண்ணிக்கோங்க.
Yes, sir.
So நம்ம பேசிக்கு A waves இருந்ததா?
No, sir. Absent A waves.
Absent A waves in atrial fibrillation. சரி.
Yes, sir.
Canon A waves இருந்தா?
Giant canon A waves.
Giant A waves. எங்க வரும்?
Pulmonary stenosis or tricuspid stenosis.
So when see right atrial pressure only you just rightly said it reflects the right atrial pressure. So anything that causes a right atrial pressure increase also, your A wave is going to be large.
Yes, sir.
In tricuspid regurgitation, your A wave can be large, and then in complete heart block, when there is dyssynchrony between the atrium and ventricle, there will be a backflow. So on the time view, A waves will be large. Yeah.
Yes, sir.
Okay. Respiratory rate of 15 per minute. What if it was 25 or 30? What will you think of?
Sir, currently hyperventilatory dyspneic, sir, in shock maybe.
It is acutely dyspnea like pulmonary edema.
Okay, sir.
Yes. Go to the next slide. Cardiovascular inspection, chest wall appears to be. Chest wall appears to be symmetrical and ellipsoid in shape. Trachea appears to be in midline. Apical impulse appears to be in the left fifth intercostal space. Epigastric pulsations visualized. No venous engorgements. You mean to say there is no precordial bulge or there is precordial bulge?
No precordial bulge, sir.
What does precordial bulge denote?
Right ventricular hypertrophy in early childhood would result to precordial bulge, sir.
Epigastric pulsations, what does that denote?
Either due to right ventricular hypertrophy, sir, or if any hepatic pulsations are seen, those can also be visualized in the epigastric area.
What is the other thing that can give a pulse in the epigastric region?
Aortic aneurysm can, sir.
So you notice the small discrepancy. You mentioned epigastric pulsation is present, but there is no precordial bulge. So clear up path to next time. Sharia?
Okay, sir. Yes, sir.
The patient doesn't have precordial bulge and there is epigastric pulsation. Fine, can be, but then more commoner is when you're commenting right ventricular hypertrophy, precordial bulge irukkaன்றது clear path to mention பண்ணு. சரியா?
Yes, sir.
Yes. Next. Tracheal position is confirmed. Apical impulse is felt in the left fifth intercostal space. Should they need to coexist every usually grade 2 parasternal heave. So what do you mean by parasternal heave?
Sir, anterior movement of the chest wall, sir. And then
Keep every popping
sir, with the palm, sir, with the base of the palm.
the base of the palm. Base
yes,
of the
sir.
fingers popping.
Thrills popping.
What is thrill?
Palpable murmur is known as a thrill.
What a thrill, Shari. Presence of diastolic thrill over precordium. Palpable P2. What does palpable P2 denote?
Pulmonary hypertension.
Yes. Yes. Go to the next slide. HR. Mitral area S1, S2 is called loud S1. So what is the mechanism for loud S1?
So due to the increased left atrial pressure, the mitral valves will open for a larger, wider area, sir. So they have to travel a longer distance to come back in position. So that produces an loud S1, sir.
Okay. With diastolic murmur of grade 4 heard with the bell of the stethoscope. So grades of diastolic murmur in
Sir, there are 4 grades in diastolic murmur, sir. Soft, moderate, loud, and loud with thrills.
Systolic?
6 grades are there, sir. Very soft, moderate, loud, loud with thrill, very loud heard with the stethoscope, and very loud when the stethoscope is a little away from the chest wall.
Tell me two examples for systolic and diastolic murmur.
Diastolic murmurs are seen in mitral stenosis and aortic regurgitation, sir. Whereas systolic murmurs are seen in mitral regurgitation, aortic stenosis, and then patent ductus arteriosus. Pansystolic murmurs.
Pansystolic murmur is seen in
mitral regurgitation, tricuspid regurgitation.
அப்புறம் இன்னும் ஒண்ணு your DST.
Yes.
Tricuspid area S1 and S2 heard. So namak ipo fairly we have an idea that our patient is a rheumatic mitral stenosis, okay, with the pulmonary hypertension.
Yes, sir.
Systolic ASMR, diastolic ARMS. So tricuspid area in this patient, that can there be any murmur?
Yes, sir. And Cardiovascular signs.
What is that?
Pansystolic murmur of tricuspid regurgitation. If it is heard, it is known as Cardiovascular signs. It is heard in the lower left sternal border, sir.
What is it due to?
Tricuspid regurgitation.
Why does tricuspid regurgitation occur here?
Sir, due to the backflow of the excess blood, sir, tricuspid regurgitation.
Functional tricuspid regurgitation that occurs due to excessive backflow from the pulmonary vessel. Pulmonary area there is S1, S2 heard, P2 is loud. Okay. Aortic area S1, S2 heard. Okay. Next. Sorry. Abdomen intended. Yes, somebody has pointed out opening snap and pre-systolic accentuation is a feature of mitral stenosis. So it will be there almost always. Yeah. What is opening snap?
Sir, it is the forceful opening of the mitral valve due to the increased left atrial pressure, sir.
Sorry. What is Okay. 4. Abdomen tender hepatomegaly, no other organomegaly. Respiratory system, bilateral basal crepitations, but no focal neurological deficits. Sherry. Okay. Go to the next. Case of acquired valvular heart disease, probably due to rheumatic etiology affecting the mitral valve, mitral stenosis with atrial fibrillation and the signs of right heart failure and pulmonary hypertension. Sherry. What is abdominojugular reflex?
Sir, on compression on the periumbilical area for 30 seconds, in normal individuals, the JVP will rise and then fall after some time, sir. Whereas in right ventricular failure patients, the JVP will be consistently raised, sir.
Okay. Good. Go to the next slide. Investigations. சொல்லுங்க என்ன பண்ணுவீங்க? Complete blood count, ESR, random blood glucose, lipid profile. Whether there should be mitral valve affected. And come to that. ECG. ECG lo what do you expect to find?
Sir, absent P wave can be
Absent
seen.
P wave. Seri. Where are the finding is cherry? Assume the patient is not in atrial fibrillation. ஏதாவது ECG finding இருக்கா? If it is a normal ECG, assume பண்ணுங்க.
Sir.
Or I'll put it this way. What are the ECG findings of mitral stenosis per se?
I don't know, sir.
Patient, first case சொன்னீங்க, patient has right ventricular hypertrophy. So, right ventricular hypertrophy ECG changes இருக்கலாம். There can be right accessible deviation. Second, P mitral அப்படின்னு ஒரு term படிச்சிருக்கீங்களா?
Left atrial enlargement.
Left atrial enlargement is going to be in mitral stenosis. That is going to cause a notched P wave. That is called P mitral. And
Yes.
since the left atrial, since there is mitral stenosis, the opening and closing of the valve is delayed. அதனால PR interval will be prolonged.
Yes, sir.
X-ray PA view. What will be the finding in X-ray chest?
Sir, left atrial enlargement will be seen, sir. So first, splaying of the carina, then left heart border straightening, and then double density sign can be seen, sir. And then
that is due to double density sign.
Sir, it's the double shadow behind the heart, the right heart, sir.
Yes, so can be due to right ventricular hypertrophy and left atrial enlargement. Sherry.
Yes.
Where what are curly B lines?
Curly B lines indicate fluid collection in the interlobular septa.
Yes. So what are the findings of pulmonary hypertension in chest X-ray?
Curly V lines and then prominent upper zone pulmonary veins, antlers on sign, sir. Then that's it, sir.
Pruning of vessels and dilatation of mean pulmonary artery அதெல்லாம் இருக்கும்ல?
Yes, sir.
Yes. Okay. Doppler of what?
Sir, echo and Doppler together,
will be done. So what will you find in echo and Doppler?
Sir, thick and immobile cusp can be seen, and then reduced diastolic filling.
You will be able to find the thick valve area, valve thickness. You will be able to find the gradient across the valve. சரியா?
Yes, sir.
Okay. So severity of MS க்கு ஏதாவது இது இருக்கா?
Wilkins echocardiography score we use, sir. And then
clinical சொல்லுங்க. A2OS interval அப்படின்னு ஒன்று இருக்கா?
Yes, sir. Severity of mitral stenosis is inversely proportional to the A2.
Inversely proportional to the A2OS interval short இருந்தா என்ன?
More severe mitral stenosis.
Okay. What about the murmur? murmur intensity.
Increase murmur intensity, increase severity of mitral stenosis.
Okay. Okay. Next. In the investigations, you have to do the PTINR also. Treatment,
Warfarin.
salt restriction, beta blockers. Warfarin, all patient or is there any criteria for that?
Atrial fibrillation patients.
Atrial fibrillation patients, you have to
INR
put
2
the patient is already having blood coagulation. What is a normal INR? Normal INR is close to 1.
1, sir.
That's the porting the raise.
Okay, sir. Yes, sir.
So, in patients with atrial fibrillation, you will put something called Chadwick score.
Yes, sir.
Yes, and the Chadwick score, if the score is more than 2, then you have to put the patient on anticoagulants.
Yes, sir.
Diuretic, digoxin, infective endocarditis prophylaxis, routine.
Okay, sir. Yes, sir.
Mitral valvotomy, percutaneous balloon valvotomy replacement. That is too extensive for you.
Yes, sir.
Okay.
Yes, sir.
Okay, let me go to the doubts. Somebody had asked me what is the mechanism of mid-diastolic murmur in MS and pre-systolic accentuation. Sorry, mid-diastolic murmur எதனால வருது? That is because the valve இதனால தான். Okay, that is a separate class in itself. நம்ம அதை அடுத்த டைம் இது பண்ணிக்கலாம். See, Hunter and Hurler syndrome, they are called mucopolysaccharidosis. Mucopolysaccharidosis are congenital defects in lipid metabolism. அது நீங்க நேம் தெரிஞ்சு வச்சுக்கிட்டீங்கன்னா போதும். You'll probably not see many cases in your entire lifetime. Those things can be associated with congenital mitral stenosis due to deposition of mucopolysaccharides. Okay. Other acquired causes for mitral stenosis apart from rheumatic heart disease வந்து ஒன்று ஞாபகம் வச்சுக்கோங்க, amyloid. இன்னொன்று, as Dr. Aishwarya mentioned, carcinoid syndrome. Look for waves in JVP. சரி, JVP வந்து அது you have to do it in practical தான் நம்ம பண்ண முடியும். இப்போ I don't think theoretically I cannot easily explain it to you. நம்ம ஏதாவது ஒரு patient இருக்கும்போது maybe we can do it. Patient only, you have to keep the patient in 45 degree and tell the patient to turn the neck to the left side and then look for the waves. Generally, you will be able to easily appreciate the waves decreasing. Otherwise, then you will identify this as a JVP apart from carotid. Sharia. Clinical criteria for MS severity again. MS severity on it is based on A2OS interval. A2OS interval short then it says that disease is severe. Okay. And mitral valve, mitral stenosis murmur intensity, the intensity is more, then the MS is more severe. Whether in all RHT mitral valve will be affected? No, doctor. RHT can be mitral stenosis, aortic regurgitation, aortic stenosis, tricuspid valve எல்லாமே affect ஆகலாம். Most common is mitral valve. Can we elicit waves clinically? Yes, pa. நீங்க அது பார்க்க தான் தெரிய வரும். I don't think in the Zoom class I can explain it. Maybe in இன்னொரு session வேணா நம்ம தனியா we can have with the patient. சரியா? Next. அவ்வளவுதானா? What is Jacob's arthropathy? Okay, next. Is there anything else? Do we need to do percussion? Percussion routine பண்ண வேண்டியதில்லை. If your examiner asks, then we can do. Okay. Atrial fibrillation present, then pre-systolic accentuation should be absent. It is variable. Sometimes it can be present, sometimes it can be absent. Pre-systolic accentuation is the murmur intensity will start to slowly increase when the systole occurs. Inspiratory and expiratory variation of murmurs. Generally, right-sided murmurs will increase in intensity on breathing in. When the patient breathes in, intrathoracic pressure will fall. So venous return will increase, more blood flow to the right side of the heart. So murmur intensity on the right side will be more. The opposite happens in expiratory. When the patient breathes out, there is more intrathoracic pressure, more blood is shunted from the lungs into the left heart. That will cause more intensity of murmurs in the left side of the heart. Okay. The time is 7:30. So how to look for pulses paradoxes? Pulses paradoxes, you have to first inflate the cuff, slowly deflate by 2 millimeters of mercury, and then you will first note that the patient, when you will first hear the beats, and the patient is expiring, and the patient is expiration, and then it will go off when the patient takes a breath. You have to then slowly reduce and see when the sound does not go up. So எப்படின்னா patient breathe out பண்ணும்போது initially உங்களுக்கு you'll be able to hear the cough sound. அதுக்கப்புறம் patient inspire பண்ணும்போது அந்த cough sound will be gone. Then you slowly reduce it further. அப்போ the sound will not disappear with inspiration and expiration. You note both those points and then you see the difference between them. That is how you measure the pulses paradoxes. Usually seen in, explain the mechanism of auscultatory gap. Auscultatory gap is usually seen in hypertensive patients. Auscultatory gap in hypertension. Yes, so mechanism for auscultatory gap, I'll just get back to you after some time. So 3 questions. 1, JVP, Jacquard's arthropathy, cardiac percussion, auscultatory gap. 4 things. Okay, we'll get back to all of this. Sharia. I think we are going past our time. We can wind up. Where the doubts are, drop them to Dr. Joel or Dr. Aishwarya, and then we can have a short write-up or summary or a discussion on these. Sharia. Okay.
Yes, sir.
Right.
Thank you.
Thank you so much. Yes, we can conclude. I hope it was helpful for all of you. After my PG period, this is the first time I'm taking class for anybody. So I hope it was worth your time. If feedbacks are drop them. We'll improve. Sharia? Good. Okay. Thank you so much. Dr. Joel, we can conclude. Yeah.
Thank you, sir, for this wonderful session. We will have our next medicine session on respiratory system tomorrow at 6:30 p.m. Thank you for joining.
Thank you. Thank you so much.